Welcome back to another installment of video Q&A session for Dermpath JC or Dermpath Journal Club. Today we have Dr. Bonnie Lee with us today. She's the senior author of the article that we're featuring in this month's Journal Club on Twitter. Dr. Lee is an associate professor of dermatology and pathology at UC Irvine, where she's also the director of the dermatology residency program and co-director of dermatopathology. She has a passion, a tremendous passion for teaching, and is recipient of the 2020 Clinical Faculty Teaching Award. She was formerly a managing director at the Ackerman Academy of Dermatopathology in New York City, where she taught numerous residents and fellows, including myself. And I'm so happy that she is joining us today for a video Q&A session. I am Silvija Gottesman. I'm a dermatopathologist at the Ackerman Academy of Dermatopathology. And here we also have Dr. Cha with us again.
Yeah, hi. Yeah, I am Jisun Cha. I'm an associate professor at Thomas Jefferson University. And I'm very excited to have a discussion with Dr. Bonnie Lee. So today we will talk about Erythema migrans. So Erythema migrans is a characteristic circular targetoid cutaneous eruption with a central clearing noted in early Lyme disease. We have been taught that the histopathologic findings of Lyme disease are those of superficial and deep perivascular lymphocytic infiltrate with the plasma cells and eosinophils. Today, we are going to discuss with Dr. Bonnie Lee about additional histologic findings that may clue us into this important diagnosis. So, how are you, Dr. Bonnie Lee, today?
I'm great. Thank you so much for having me. I'm very honored to be here, and I'm very proud to see Dr. Gottesman so involved in the ASDP, and I'm looking forward to our conversation.
Thank you very much for joining us. So yeah, we have this first question. So the introduction of your article, the authors mentioned that serologic testing of early Lyme disease may have increased numbers of false negative results. Can you elaborate as to why and whether there is a recommended window after tick bites for serologic testing to be done?
Well, I think, it takes a while to form antibodies to any sort of infection. So it does take a while to kind of be able to measure that effect. And it sort of depends on how much bacteria is how many spirochetes are injected at the time of the tick bite. And I think it's sort of hard because you have to bring a little bit of the clinical scenario in. If a patient comes to see you and they just had their tick bite, are you really going to send them away and have them come back in 2 weeks for the test? So I think that generally, if it looks clinically obvious, like you have erythema migrans, they had some recent updated recommendations that came out that say you don't even need to test it. You can diagnose it clinically. The sensitivity early on is only 30 to 40%. Later on in what's called the convalescent stage, about 30 days in, it's maybe 60%. And certainly if they've developed disseminated disease, it's much higher. So you just have to keep in the back of your mind that early on, your sensitivity is low. I think there were some rabbit studies, which may not correlate exactly with humans, but they showed how the spirochete load increases from day 7 to day 14 and things like that. So it probably just takes a little time to get going, and it really depends on when your patient comes in.
Before I pose the next question, I want to share screen and bring up one of the key figures from the article and just have Dr. Lee briefly discuss their novel pattern findings that could help us clue us into this diagnosis. Let me see if this works out well. Are you able to see it?
Yes.
Okay. Yes. Well, I think it's important to first note that there's really no good finding for erythema migrans. And we're taught, because it's like a gyrate erythema in the beginning, that's very much a lymphocytic infiltrate. So in the textbooks, historically, we've viewed it as sort of a more dense, superficial and deep and even interstitial infiltrate, plus or minus EOs, plus or minus plasma cells, depending maybe on the acuity of the process. But I think recently there's been a number of articles that have sort of highlighted the fact that there's quite a range of histopathologic findings. And it could be either very sparse and just superficial, or it could be very dense and superficial and deep. And so, what really helps us diagnose this? Well, this sort of raises the issue that we wanted to explore later in a follow-up paper before I decided to leave the academy, of these sort of elongated cells. One thing that we found in our study that has been shown before, but we sort of showed it at a higher incidence than I think other papers, is that you do have this very subtle interface in the majority of the cases. And whether your infiltrate is superficial and sparse or superficial, deep, interstitial, and dense, we tended to see, because we were looking for it, right? I think it was probably reported less in prior papers because they weren't hunting for those two cells that we could count as interface. But there was almost always this little subtle interface, and that clued us in to think about erythema migrans, certainly if it correlated clinically. And then, a hot topic at our laboratory, both when I was in Portchester before I was at the academy and when you were there, Sylvie, is these elongated cells. So I was taught, we used to call them squiggle cells. And I was taught they were probably activated lymphocytes, these squiggle cells. But I've since decided that it makes more sense that they're probably these new cells that everybody's talking about, the dendritic cells. Mm-hmm. And these dendritic cells are actually, part of the innate immune response. So kind of like Langerhans cells or the dendritic cells of the epidermis. And then there's these dermal dendritic cells that really hang out in the superficial dermis. And then actually they're a separate population from the macrophages or histiocytes that we see in the superficial perivascular region. And these dendritic cells, as part of the innate immune response, as soon as there's exposure to a microbe or an allergen, they're going to activate and serve as an antigen presenting cell to then the adaptive immune response, where then the lymphocytes will come and the rest of your immune response will happen. Mm-hmm. And so what we know, regardless, and there's been animal studies and there's not a lot of data in these specific biopsies where we know that there's an infection involved. Well, what exactly are these cells? Because I show here in these arrows, these elongated cells that we know, and sometimes they're in the epidermis and sometimes they're at the DJ. Sometimes we see them close to the superficial plexus. It's hard to know if they're Langerhans cells, though usually you can see the little groove with a Langerhans cell, or if they're these dermal dendritic cells, or if they're funny lymphocytes, right? But that was what I was hoping to study next. But now I've got to start over and collect a large cohort of proven infectious cases to sort of study these cells. But these cells are something that I learned to look for when you look at an interface process, because what do we normally see with an interface? Let's say you have a superficial perivascular dermatitis with a subtle interface, and people are like, virus versus drug. And then you just say, sure, virus versus drug. And you can't always elaborate beyond that. But when you see these elongated cells, which since learning them as squiggle cells, I talked to Dr. Phil LeBois once, and they call them twistiocytes. So I've now adopted, in an attempt at uniformity, the term twistiocytes. So when you see these twistiocytes, it should heighten your sensitivity towards the possibility of something like a microbe. And so when I see an interface that's otherwise not significant, could be virus, could be drug, if I see those twistiocytes, I favor a virus. We noted these cells with rickettsial pox infections. We note them in erythema multiforme. If we see them, we favor herpes virus associated. We had one where one of our pathologists could swear it was herpes virus associated, but it turned out to be mycoplasma associated. Not only viral exanthem, you see them in syphilis. And then certainly here I noted, not only do you see this interface, but you see the elongated cells. And that's what clued me in to think, oh, maybe this is really erythema migrans. So that was something that we saw. And our index case, which I talked about, was, it came in, of course, I didn't get a lot of clinical information. That was being at a private lab, right? Now I have this whole epic chart, which is just wonderful. But this case came in and I swear there was like 10 lymphocytes per vessel. It was so sparse. There was almost nothing there and just the subtle interface. And I said, viral exanthem. And then sure enough, eventually it came back and the dermatologist said, oh, actually, no, it's Erythema migrans. And the patient tested positive serologically. And then I saw the clinical image and it was pretty obvious that it was Erythema migrans. But that's sort of what sparked this, because I was like, oh, I see that twistiocyte. And then, going back to the literature, people have noted it. So then we're like, well, it's Lyme season here in New York at the time. So why don't we just collect all of our cases and look at them and see how prevalent this is? And that's kind of why the paper started.
That's very cool. I actually, this was the favorite part of my favorite part of the article, looking at the squiggly cells. And now I know another terminology is a twistiocytes. It's very interesting. Yeah, so actually I was going to ask you whether this was a lymphocyte or this keratinocytes, but most likely this is one of those innate inflammatory cells like lymphocytes or natural killer cells or
Well, they call them the dermal dendritic cells right now. That's their name. They don't really have a better name than that.
I see.
Although the Langerhans cells also migrate back to the lymphatics once they sample their little target antigen. And it's interesting, you can see motility videos in some basic science papers where, I always tell my residents, oh, dendritic means they have the little arms that stick out. But what happens is the dendrites go away and they move in pseudopods. So they do move into this elongated shape. And so I started collecting all sorts of infectious cases to start staining and seeing if they stain the way the dermal dendritic cells stain, which is more with like CD1, B and C, plus or minus with CD1A that the Langerhans cells stain with, maybe CD11, things like that, as opposed to a lymphocyte marker. But then I left. So.
Okay, but I will look forward to see the next article.
Give me 5 years.
Yeah.
I agree with Dr. Chada. This was probably the most exciting part of the paper for me, because to see them printed and how you've always taught me about them, and ever since you left the academy, every single resident that has come through here and fellow, I've told them these squiggly cells, Dr. Bonnie Lee, probably viral exanthem, favor that. Can't exclude drug, but favor viral. Ask more questions from the patients.
Well, I have to credit my mentors, Mark Jacobson, who taught me about them, and Damien DiCostanza, who followed up on that case with me when he told me I was wrong. And he was the one that had the mycoplasma case to add another infection to the squiggly cell list. So
it's just fantastic how we all contribute to the literature. A lot of clinicians, whenever there's a question about Lyme, they ask to do the silver stain. And in my experience, it has been a foolish and hopeless pursuit, because either of low numbers of organisms present or background staining that is ambiguous. So we don't have at my lab the Borrelia immunostain, but for the ones that do, amazing. And have you had any experience with it? Are you able to tell us where could we look for the organisms? Yes, yeah, maybe start from there.
So that's a really good question. And actually, I think very few labs use a Borrelia specific IHC, and you can't really find images in the literature on where it stains. And this actually sparked another debate at the lab. Anytime I miss something or I argue with somebody about something, that's what sparks my project ideas. And this was another project that unfortunately fell through, but Jeff Gottlieb was one of the original people that was able to see the organism, the spirochete in the superficial plexus. So that's why most people think of the organism as being there. Now, the problem with the silver stain is, the melanocytes have the dendritic processes in the epidermis, right, where the melanin is, and that can look identical to a quaily spirochete. And so in these cases where I knew it was positive and I did the stain, I was, of course, cruising at 40 and 60x looking at it. And I'm like, oh, I swear this has got to be a spirochete. And he's like, no, they're not in the epidermis. And I was like, well, in syphilis, they're in the epidermis. So why isn't that possible? So then we had a huge debate, and it turns out they have an immunostain at the CDC. And the CDC was staining, they were interested in staining like heart specimens. They'd never actually demonstrated that it worked in the skin. And so we were going to collaborate. As I was getting this IRB together, we were going to collaborate, and I was going to send all my specimens to them, and they were going to stain them for me for free. But that was right around the time of a presidential administration change. And eventually the funding was cut, and they were not able to do it with us. So that was another lost opportunity. So I'm actually not sure. I sort of believe I saw them in the epidermis, but you know, I'm not sure.
To be determined in a future.
Yes, but I don't have access to a Borrelia immunostain that's specific.
I have seen the mast cells in one of my cases of Lyme disease. Have you noticed any presence of mast cells in your cases?
I didn't look for it specifically, but you know, it is known that the spirochete can degranulate mast cells. And it also makes sense from a clinical standpoint because your initial reaction to the tick bite is a hypersensitivity reaction. So I wouldn't be surprised that there are a lot of mast cells, but I haven't looked at it specifically. And sometimes I have a hard time without doing a stain of really quantifying how many there are. And in private practice, we try to limit our stains as much as possible. Now in academics, I probably can be a little more liberal with it, but I still, you know, it's hard to break that habit. So I'm not actually sure, but I would assume that there are more mast cells, certainly with the initial bite reaction.
Now you're in West Coast, right? So you probably don't see.
I will never be a Lyme expert.
Maybe Silvija should send you those blocks that you have.
Yes, you know, well, it was great. I had a lot of Lyme and I had a lot of syphilis, and now I have a lot of melanoma. So yeah, it'll take a while to collect things.
Unfortunately, still a lot of syphilis in you. Jisun, maybe you can ask the next question because we already talked about the squigliocytes.
Yeah, so the next question is maybe, I mean, I don't know if anybody will have the answer for this question, but just in case, like some studies note that the central portion of an early lesion of Lyme disease may have more eosinophils, and the peripheral lesion may have more plasma cells. And you mentioned in the article that there were no specific information in the requisition slip whether the lesion was biopsied from central portion or peripheral lesion. Do you have any idea where would be the best spot to do the biopsy for the best yield? Like a central portion or a central clearing area or erythematous peripheral rim? Do you have any idea, or was there any study on this?
You know, I think historically they've talked about that, and it also makes sense from a clinical standpoint, right? Initially there's an allergic reaction, so you'd expect eosinophils, and then later I always tell my residents, you know, plasma cells are a sign of chronicity, right? And so as the reaction progresses and is there for a longer period of time, your advancing edge might have more plasma cells. So it's great theoretically. I never got information on where it was biopsied. And actually, the majority of the photos that I received of the patients that had it, it wasn't even necessarily that annular. It was always very impressively red everywhere. So I think for me, as a general rule, as a dermatologist, I try to biopsy where it's red because that's where it looks inflamed. So I think wherever you biopsy, the findings are so variable, which, you know, there was one study where I saw they biopsied, you know, from the same lesion, the center and the edge, and they weren't looking at the histopathologic findings, but they were looking at whether they could detect organism, and they could detect them equally. So actually after the lesion fades, you can actually detect the organism there. So it's hard to know if it's more how much organism was injected, the time course of when it was injected, the person's own immune response that determines it more. So I generally go for where it's red.
It's safe to say that in Erythema multiforme, biopsy the center of the targetoid lesion, but in Erythema Chronicum migrans, because the central area, there's clearing, biopsy anywhere on that rim. And if there's no targetoid lesion, anywhere where it's red.
Maybe, but I will say there's a caveat to the erythema multiforme thing too, because certainly if you have any vesiculation in the center, or if you have significant necrosis, would you want to read that biopsy? You know, after something's blistered and the epidermis is dead, it's very hard. I like to see the little clumps of necrotics and the interface. So I'd still rather see where it's a little red or dusky than where it might be a little too necrotic or old. So I guess I would still target the red or dusky area on that lesion. But it's good to go in with a plan.
In the perfect world, it would be nice to have like two biopsies, one from the center, one from the periphery, with indicating where the biopsy is from. That would be nice.
Be sent with a clinical photo.
Yes, attach it with a clinical photo.
Well, this has been very illuminating and very exciting to have you here, Dr. Lee. We always have, most of the time, the fourth Thursday is the Dermatopathology Journal Club at 9 p.m. Eastern time, unless it changes because of holidays. So we are having it tomorrow, and I know all of our participants will be excited to watch this video. And if there are any follow-up questions that are really interesting, I'll make sure to get them back to you.
Wonderful. Thank you so much.
Thank you so much for joining us today.
Take care.
Bye.